Okay. Um, First of all, Assalamualaikum and a very good morning, ladies and gentlemen. We are from the Society of Cancer Advocacy and Awareness, Kuching SCAN. We welcome you to this second edition of our webinar series. We are pleased to introduce to you Dr Adibah Ali. She's a breast and endocrine surgeon at the Sarawak General Hospital, and she'll be speaking about breast cancer and COVID-19. The title of her presentation this evening is Cancer Treatment, Should I Go Under the Knife Now? The talk this evening is going to be about 20 to 30 minutes. If you have any questions, please type them in the chat box in Zoom. Your questions will be answered at the end of the presentation. So without further ado,
thank you, Dr. Fitri. Hi, everyone. I'm glad that we have received an overwhelming response from the participants. Hope you all are doing well at home now. So last Wednesday, we had a very fruitful session with Dr. Chu on what cancer patients should know and do in this COVID situation. So now, tonight, I'm going to take you all through our experience managing cancer patients in surgical perspective during this COVID situation. And of course, highlighting the main question is, should you go for surgery at this moment? Okay, if we talk about surgery, it comprises main three components: how we get into the diagnosis by means of imaging, like doing the x-rays, doing the CT scans and biopsies. Either we are doing it open or endoscopic method. And then pre-op, how do we prepare the patients for surgery? And post-operative care after we complete the surgery. Time of this COVID. So it's different than what we have done before the COVID situation. And our MOH guideline changes almost every 2 to 3 weeks, influenced by current number of cases. So there are a lot of factors that need to be considered during this time. So the impacts on the prognosis or survival, and what are the measures taken to reduce the impact. So we are worried of the prediction of there will be reduction of survival rate in next 5 years are reduced will be true because of the pandemic. So there are few problems that we have faced during this issue. The first one, of course, there are stigma of afraid to come to the clinic among patients, even they have experienced early sign of cancer, like breast lump, chronic epigastric pain, and bleeding per rectum. Besides that, there is significantly reduced attendance of patients for screening program, like mammogram. They are afraid to go presenting complaints. So, of course, if there's no early detection like mammogram, there will be delayed in diagnosis. There will be failure to detect early stage of breast cancer. So to overcome this, we should think of increased awareness of infection control, increase the testing for COVID availabilities to allow the service continues. Screening can be performed at less crowded medical facilities, non-COVID hospital. So besides that, according to WHO, if you see the second row here, there are certain medical procedures are high risk because there are aerosol generating procedures causing airborne transmission, like the procedures like bronchoscopy, gastroscopy, and colonoscopy. So now we tend to select patients strictly for these procedures. The impact is we may have missed the patients with cancer. So there will be delayed in diagnosis. Again, if we have enough testing for COVID and patient with COVID, preferably also done in non-COVID center, at least we can perform these procedures with safety. But however, if we don't have any choice, we will perform with the airborne precaution. So the other thing is option of type of surgery is also influenced by the pandemic. Certain surgery for cancers previously best treated laparoscopically. Laparoscopy results better surgical outcome and reduced morbidity. In view of laparoscopic is aerosol generating procedures, as what I mentioned, it can cause airborne transmission. we have to perform some surgeries as open instead of laparoscopy. So performing surgeries in COVID patient, they will contaminate the clean and sterility of the OT. So with the contamination, the risk of infection will be high in surgeries who required implant or prosthesis. So that's what we are doing now. We have to separate the OT. We have dedicated OT for the T cases, clean cases. So we are using the laminar floor. Issues that we are facing now is we have lack of beds and wards. Most surgical wards capacity are reduced to 50%. Instead of 20 to 30 beds, we have to combine with other disciplines. Left with at least 10 beds left to the surgical site. So the whole main block of SGH are converted into dirty wards. Our staff medical officers and nurses are also deployed to the frontliner team. So PPEs are also prioritized to the frontliners. So the huge impacts on us that we can only perform semi-elective cases, drastically reduce the operating slots, postponement of cases resulting in increased waiting time for the cancer cases. In order to keep continuing the care of cancer cases, so what we did is we have diverted the cases to certain centers like Pusat Jantung Hospital and other district hospitals. So like in West Malaysia, what we did is we have arranged MOU with the private hospital, so which can buy services from there, which partially subsidized by the government, and some of the backlog cases. So lastly, the main issue that we can't help much are the lack of ICU beds, blood storage in blood bank. Now, we can't perform much major surgeries as the ICU is reserved for the COVID patients and blood are reserved for the life-threatening emergency cases. But sometimes we will still counsel patients' relative if they would like to donate the blood to support their relative surgery. So when we talk about selecting patients strictly for surgery, there are a few criteria that will be considered. We have to prioritize the cases. As in general, we have to screen the patients preoperatively to ensure that they do not have the history of contact, travel, or symptoms of COVID. So the cases chosen has to be straightforward cases, less morbidity, which do not anticipating blood transfusion or ICU admission. So the priority will be given specifically for cases which cancer complicated, like blockage of the colon, obstruction, like colon CA, if they have obstructed, they tend to perforate. So that's where the priorities, the cases goes to. And those who do not respond to chemotherapy. So when we're giving patient chemotherapy, if they do not respond well to the chemo, that's where we prioritize the case. So back to the question, whether does the patient need to undergo the surgery is this critical time. So if yes, we need to adhere to the guidelines set up by the MOH. Is either patients required to undergo the PCR test to ensure they are COVID-free before the op, or if it is not feasible because of inadequate facilities, we are lacking of the COVID test currently. So the healthcare need to wear a complete PPE protection because our healthcare need to protect ourselves. Right now, we are not sure whether who else is infected or not. So what about if in certain circumstances where patients cannot undergo surgery, like certain for now. So in worst scenario, do they have any other alternative options? So in my next, okay, this just to example, this how we wear PPE for PPA in operating at the moment. It has 3 layers. It's very hot, and with the shield, it's fogging, and it's not easy for us to see what operation that our operative field. So in my next few slides, since I'm a breast surgeon with the background knowledge of other cancers categorized under general surgery, I will explain on the alternatives that can be offered besides surgery during this situation. So, but I will emphasize on the breast and colon cancer, since there are 2 common cancers which require urgent surgery, in which if these surgeries are delayed, the survival is compromised. So as an endocrine surgeon as well, I'm not worried much on the thyroid cancer because it is an indolent tumor where it is progressive, it progresses very slow. So if without area obstruction, delay in I don't have much knowledge in other cancer like bladder, prostate, which under urology, and uterine, ovary, or cervix, which under gynecology. So you can always discuss with respective specialty for further options in above cancer. So the breast cancer prioritization, when do we actually prioritize the breast cancer patients? So the first one, if the neoadjuvant patients finishing the treatment. Neoadjuvant means that patients receive the chemotherapy before the surgery. So when they have the finished treatment, they have to have the certain window period between 3 weeks to 6 weeks to do the surgery. So we need to prioritize, because delayed in this period window, it may cause the breast cancer to develop, progress. So the second one is the clinical stage T2, means that tumor size 2 to 5 centimeter. They are hormone positive, so HER2 negative. So this stage actually does not respond well to the hormonal group of patients. Triple negative or HER2 positive patients or early breast cancer, which is resectable, because triple negative or HER2 positive, they are more aggressive. They can't wait much. So we need to prioritize these patients. Discordant biopsy like to be malignant, means that if let's say the imaging of mammogram showed very suspicious, but then the biopsy came back as negative. So there are discordant between these two investigations. So that's where we plan for wide local excision to confirm these are not CA. So this will need to prioritize. And excision of malignant recurrence means that, let's say breast cancer, they have completed the treatment, but they came with a new lesion. So this thing, we know that this is recurrent. We will prioritize this case as well. So there are cases that which can be delayed, like excision of benign lesions, fibroadenomas, nodules, ductal excision, discordant biopsy, these images and the biopsy. High-risk lesion, papillomas, where you know that these lesions can cause cancer, but not at the moment yet, so we can defer these cases. Prophylactic surgery for cancer and non-cancer cases means, like, let's say the patient have breast cancer with BRCA positive, and then they have benefit in doing prophylactic, means the other side is not affected yet, but there is benefit of doing surgery on the other side. But it's just called prophylactic surgery. It's not a treatment yet. So we can defer these cases. Delayed sentinel lymph node for cancer identified. Let's say the patient came in with breast cancer, we have excised, and patient has to undergo for second surgery, like sentinel lymph node. We can actually defer this patient. So early carcinoma ductal in situ, mean that it is invasive lesion, but if it is hormonal positive, we can delay this patient. Re-excision adequately excised. Can re-excise surgery. This also we can defer the case patients. Tumors responding to neoadjuvant. This is adopted from the American College Surgeons. Okay, and then tumors responding to neoadjuvant hormonal treatment. Okay, so where some of the patient we may offer them neoadjuvant, means that we're giving chemo before the surgery. So if those tumors are responding well to neoadjuvant, we can postpone the treatment for surgery first. Clinical stage 1, T1 and 0, receptor positive, means that early breast cancer, but if they are hormonal positive, we can counsel the patient to defer the surgery. And inflammatory and locally advanced breast cancer, so locally advanced breast cancer, we can offer the patient for neoadjuvant chemotherapy. So I hope that I'm not that way. If in critical situation, if we cannot perform the surgery, what are available options? So for this hormonal positive breast cancer, we can offer them as a hormonal, as a neoadjuvant, where let's say patients are ER/PR positive, HER2 negative, and they cannot undergo for surgery. So there's option of giving the hormonal for them to buy time to get our surgical date. And then if they are triple negative and HER2 positive, we can offer them as neoadjuvant chemotherapy. So this we will discuss with the oncologist, whether they are suitable for this option treatments. What about the colon cancer prioritization? Okay, I just touched, because colon cancer is also most common cancer that requires surgery, where if we delay the surgery, it can compromise the outcome. Okay, let's say the colon cancer, it's nearly obstructing colon. Let's say this is what I have mentioned earlier. Cancers require frequent transfusion. Let's say the patient have multiple admissions due to rectal bleeding. So they really need the frequent transfusion. So we will prioritize the patient. Rectal cancer after neoadjuvant chemo radiation with no response to therapy. So where we opt the patient for neoadjuvant therapy, they don't have the response toward this therapy, so we'll prioritize the patient. Cancers with concern about local perforation, where this, as I've mentioned just now, they tend to have infection, perforation, we will prioritize the patient. And early stage cancer, rectal cancer, where adjuvant therapy not appropriate. So there are certain patients are not appropriate for this chemotherapy. So we need to prioritize this patient. So there are types of colon which pre-malignant disease. I mean, it is not developed cancer yet, but they can develop and deferred if they are like malignant polyps, but we have excised it endoscopically. Prophylactic indication for hereditary conditions is just like those who have familial adenomatous polyposis, their familial condition, where we need to remove the whole colon because this in later age, they can develop cancer. So we can defer that as well. First, large benign appearing asymptomatic polyps, like these polyps looks like cancerous, but it's large, but it's still benign. So we can defer these patients. Small asymptomatic colon and rectal carcinoma is a type of colon tumor as well. But if it is small and asymptomatic, we also can defer. So in this colon, if surgery is not feasible, what are the available options that we have? So usually if locally advanced, resectable, we can resect the colon cancer, but they are okay. So for locally advanced resectable colon cancer, we can offer them chemotherapy for 2 to 3 months followed by surgery. So there are options. We don't have to go for surgery, but if the patient cannot go for surgery, we can offer all this chemotherapy. And then the rectal cancer with clear and early evidence of downstaging from neoadjuvant chemo radiation. So where additional wait time is quite safe, but we may need additional chemotherapy while waiting for the surgery. Okay, this is also the same. All these cancers, we can actually, with advice with the oncologist, we can deal additional chemotherapy can be administered. And the last one is the oligomets. It means that if the cancer is spread to other organs. Okay, so as what I've been mentioned earlier, um, we have slightly changed on the preoperative planning. Perform surgical cancer in all the patients, but now we have to be very selective. We do not want to expose ourselves because during the surgery we are exposed to the blood fluid. It is airborne transmission because during intubation they can cause airborne transmission. It's not like droplets anymore. So we have to ensure these patients are COVID-free. So we will call them 3 to 4 days prior to update. We will screen for any symptoms, whether they have any history of travel and contact. Of course, in the MOH guideline, they have to do swab tests for all patients before the surgery. But right now, we cannot do that because we are lacking of the swab test. So the other options is we will perform the surgery in the full PPE site. Okay, post-op, Shorten post-op, of course, they'll be slightly different as well. First of all, we will shorten duration of length of the patient at least 2 to 3 days. But now some patient may be discharged immediately post-op with drains because we wanted to reduce the risk for the patient as well. So we want to discharge them as well, and we can continue the treatment as outpatient. Some patients, we may continue treatment as telemedicine, where they can freely call our clinic and advise help. And sometimes we can call them, right? And then medications, they don't have to come, and then it can be postage. So in conclusion, there is actually high impact on cancer treatment during this COVID-19 pandemic. So delayed surgical treatment more than 1 month, it reduces survival rate. But if we have this alternative treatment like hormonal treatment, chemotherapy as neoadjuvant, while waiting for surgery, that is an option. So multidisciplinary approach between oncologists and surgeons are very crucial. I hope I'm not that fast. Okay, thank you. I stay here for you. You stay home for us. Oh, okay. So question, let me see the question. Which are the private hospitals that are currently MOH patients can go for surgery? In Peninsular Malaysia, they have a list, but right now in Sarawak now, since we can still perform the surgery in Pusat Jantung, we have not yet have any discussion with the private hospital. So we still can perform in the government hospital. Few of them, they will list out and give the patients options. It will be discussed by the respective breast surgeon in the MOH. Okay. Government is partially paying for public hospital patients who will be referring to private hospital. Who pays the remaining costs, especially if patient is from B40 group? It is subsidized by government. I do not know how does the, as I said, we have not started in our place yet, so I do not know what. But then there is a discussion that if we cannot perform in our government hospital, our government will be paying for the service in the private hospital, but it's a low cost. Is the new KPJ ready for use? Is the government planning to use it? I don't think so. I don't think so. Okay. So if someone detects a breast lump, do you advise them to go to SGH breast center? Okay. Currently, the SGH breast center is still a referral center, means that if you have detect a breast lump, you still have to go to the clinic kesihatan, nearest polyclinic. So they will refer to us directly, but we won't give that long appointment. You can actually get the appointment within 1 week, but means that there's no delay in the not much delay in the early referral. For patients who have finished core treatment and due for follow-up or monitoring like mammogram, how much can delay the follow-up? So actually, how long they can delay, I can say that right now, we're not advising you all to come to hospital for follow-up or monitoring. So what we advise the patient, you can always have in any changes, you can feel the lump, you can come as early as possible. But how long we can delay sometimes, right now, our postponement cases is up to 2 to 6 months. So what we do in the clinic, we have piles of clinic card. So we have a team of reading the cards thoroughly. So we will discuss which patients to be postponed. So usually if the follow-up, we will just postpone the cases. But for the reviewing of the histopathology, which needs urgent review, we will just keep the existing appointment, because we do not want to risk the patients as well, you see.
Any other questions? We can probably give them a few more minutes.
I've unmuted all of you, so you can just ask your question if you prefer to speak.
How can I help to give a scan? You all have been doing a very good job. Yeah, we don't have peer counseling at the moment. As scan only like you contact others, I think that always be approachable. But as scan, I think you just can continue whatever you like, you know, like this telemedicine thing. And since now we can do counseling, yeah, you can do have this kind of Zoom. What you're doing right now is actually is good. Group. And some of them, they may contact you personally, and they may have, I mean, like you have other ways of connecting to each other.
Any more questions? No? It's gone quiet in the chat box.
I think there's
Yeah.
another question inside the chat box.
Since
Biopsy.
now we can do counseling in GH. I don't understand. Is it since now we can do peer counseling in GH biopsy, or I don't get the question. We still do biopsy. Is it still on GH? I don't get the question. Since now,
Biopsy is still being done then, correct?
Dr. Adibah.
oh, okay, biopsy is okay. Patient, yes. Biopsy, yes. We still do biopsy. As what all the suspected cases, all new cases, we still review the new cases as well. And if it is suspicious, we still perform the biopsy. And the length of waiting time to biopsy is still the same. If it is suspicious, we still proceed immediately after we see the patient in the clinic. We do for them, yes. I hope it's answered the question.
I have one more question. How much more difficult is it to do a surgery while in that 3 layers of PPE and a face shield?
Very difficult. It's fogging, and then I had, I think I had during my on-call last week, where I had this perforation and repairing the stomach, where I have only small window where can I see. But actually there is a device we call a respirator. So it's it is quite good, but it has just arrived. It is very limited because each patient need to use filter, so the filter has to be changed. We cannot once, and that filter is quite expensive. So we can only wear that for if we want to do the aerosol generalized procedure like scope, because we are exposed to the airway, direct to the airway, and patient if suspected PUI or COVID. But then the rest of the patients, we have to wear the normal conventional face shield. It's quite, I was complaining and was complaining actually a lot.
There's one more question in the chat box.
Yeah, let's
Okay.
do that one first.
Patient need, can lumpectomy be done in a clinical setting? Yes, lumpectomy, I think. No, you cannot do lumpectomy in the normal. It has to be done in clinic, where uh, it depends on the lump. Okay, if the lump is purely benign, we will defer the surgery. We will do after the pandemic is a little bit settled. But if it is, we can do under local anesthetic. So it has to be in sterile procedures. It has to be in sterile area. But then if it is quite a large lump, we need a proper wide local excision with a good margin. For suspicious breast lump, it has to be done in OP. So for the suspicious lump, we will not postpone. We will still continue and prioritize the patient. Chemotherapy is full swing still in GH. Social distancing on 1 meter is practiced for all this treatment. Yes, if you can see, chemotherapy is full swing still in GH. But what I know, they still continue with the chemotherapy. We cannot postpone all these important treatment. But then we have to take some of the precautions. Social distancing, yes, it's everywhere in SGH. If you see in my clinic as well, we will put cross in each alternate, only like one line of chairs. One line of bench. We can only one person can sit. So we practice. Actually, Sarawak General Hospital, they are very strict and adhered to the WHO or CDC guidelines. Means like for operating theatre, we have two sides: dirty operating theatre and clean. So which dirty is specifically for PUI, those who have respiratory problems and COVID, and clean are for the other OT. We have clean ward. Now we are located, our surgical ward is evacuated. Now we are located at the other clean ward. And then even the route, the elevator, the lift are also separated. So worry. Actually, we are actually practicing the complete precautions. Are there any options for other forms of treatment that can help reduce lump for breast cancer patient whose surgery? Okay, I think I have in one of my slides. Okay, this is the one. Okay, so if surgery is not feasible, the available options that we can offer is we can offer the hormonal therapy as neoadjuvant. It's like tamoxifen, also hormonal, and then because this can help to reduce the size and just, but at least they can maintain, just prevent it from its progress. And the other one is those who have triple negative and HER2 positive, we can offer them for chemotherapy. So some of these triple negative and HER2 are responding very well to the neoadjuvant chemo. Sometimes they can cause complete response. When the patient comes with big lump, when they started with neoadjuvant chemo, you cannot palpate the lump after the chemotherapy. So there are options. Yeah, the one that I have said in the presentation.
Right. We don't have any more new questions so far. Anybody else? Chris, maybe we try to unmute again. Maybe people have questions that they want to ask.
Anyone with any final question?
Hello.
Hello, hi. Yes.
Dr. Adibah?
Yes, I can hear you.
Just now, when you mentioned clean versus dirty when you talk about operating theater, you actually have now segregate those. Maybe you can explain what do you mean by dirty versus clean?
Okay. If dirty, if dirty operation theater, there's only few people into that OT. Everyone should be in the PPE. So there are a lot of procedures that need to be undergone, like let's say our SOP is like when we enter, we have full PPE, and then after everyone is on PPE, then we call the patient, and after the patient is in the theater, because you know these are airborne transmission. So a lot of SOP, and then nobody is allowed to go in while the operating theater is there. So this dirty theater means that it's specifically for those who are suspected for COVID, have the respiratory problems where we do not know the status, because the test usually takes about days to come. So we will assume they are COVID unless proven otherwise. We don't have time for the test to come back. We will perform this type of cases in the dirty theater. It's not like the dirty. They have extra, the negative pressure lamina OT. So they have actually, it's a little bit better than the conventional theater that we usually perform our cases.
Okay, thank you so much.
All right. Thank you so much.
Thank you.
Any more questions?
Thank you for your time.
Yeah. Keep safe. Bye, everyone.
All right.
All right, before everyone goes, can just fill in the feedback form. I've posted it in the group chat. Just copy that address and put it into a browser and fill in the feedback form for our webinar. We want to see how well we are doing and how we can improve. And thank you again, Dr. Adibah, for this informative talk.
Yeah. We really hope that everything is.
Now I know what a dirty operating theater is.
Yeah, I hope everything will be over as soon as possible. Everyone has, everyone got the impact.
I'll call it a for this evening. Thank you very much again, Dr. Adibah, for a very interesting presentation this evening. We've certainly learned a lot from you. And thank you for everyone who have joined us for this session. This is our second webinar for this during this MCO actually. We hope to be able to host more, and we will continuously announce the upcoming webinars in our. So do check in and to find out what else we have for you.
There should be one on Tuesday, 8 p.m. as well. Thank you, everybody. Have a good night.
Bye. Bye, everybody. Bye.
Bye.
Thank you, Dr. Adibah. Thank you,
Thank
Dr.
you
Fitri,
for
for
your
emceeing
time.
this
Thank you,
time.
Dr. Fitri. Please.
Thank you, Dr. Adibah. Thank you, Dr.
Bye.
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 Bye, Bye.
Bye-bye.